My pleasure to welcome you to another session of Radiology Grand Rounds with Health for the World. And today our speaker is Dr. Jonathan Alis, who will be giving a talk entitled Imaging of Thoracic Trauma. Dr. Alis is the Director of Cardiothoracic Imaging at Jacobi Medical Center and also an Assistant Professor of Radiology at Albert Einstein College of Medicine. He completed both his residency and fellowship at Montefiore Medical Center in the Bronx, New York. Please, everybody, feel free to share where you're joining us from in the chat. And at the end of the session, there'll be a Q&A session as well. And with that, I'll hand the platform over to Dr. Alis.
Okay. Hello, everybody. Great privilege. Thank you for having me. I'm sometimes a little technically challenged, so you have to help me and bear with me. I'll do my best. Okay, so we're going to discuss imaging of thoracic trauma. Jacobi Medical Center is a level 1 trauma center, so we see, I guess, the most significant trauma, gunshots, stab wounds, and motor vehicle accidents. And I'd like to sort of touch a pace. Really, when it comes to thoracic, there's going to be vascular, which is aortic, and maybe I'll leave that for another chance, another time to come back. But I will focusing more on parenchymal thoracic type findings. This is a screen that you can view. This is a scout radiograph that was taken from a barium enema recently that was given to me by one of my residents, and you can see, I think, sums up quite a lot that's going on. So you can see here, I think this is a lighter. I was trying to work out if it was a vaping device or not, but I think it's just a standard old lighter. Here's his cell phone. He's got his clothes on, so he's got some zips. He has a bullet here. He's been shot once before. And there in his jacket that he refused to take off is his gun. And when the resident saw this, he was like, okay, I think this might be a good reason to terminate the barium enema. So this was quite a novel way of trying to stop doing barium enemas. Moving on. So we're going to discuss, hopefully, the way I'd like to do it, and this really I'm just basing on the way I find learning helpful. I feel as radiologists, we see the actual study. So as opposed to a lot of static images, I'm going to try to show you DICOMs. The whole study, try and scan through them. And in that way, hopefully, it will be a little bit more educational. Hopefully. Okay, so case 1 is going to be this case. So I'm going to basically, a lot of these things being trauma, they're not diagnostic dilemmas, but the couple of things I want to just give across will be, we'll discuss, I just want to show you a few things. And so essentially, I'm not going to discuss a systematic way of reading every study and every trauma that you obviously need to have as you do for every study. But I'm just going to try and focus, in the interest of time, and focus on the findings that I want to really bring out. So what's interesting is you can note here, just off the bat, we can see patients already had a chest tube. It's often the case that before they come to imaging, they're going to already have had interventions on the field. They have another chest tube here. And you can see what, at this point in time, I'm going to just describe as an opacity. You can see an opacity that sort of travels along here in a linear way along the parenchyma of the right middle lobe. The vast majority of it here, you can see the right middle lobe bronchi coming off. So we have a very linear type opacity, but it travels through the fissure. And the first thing I want to bring out to you, and I think is very relevant, really significantly so in all chest imaging, often clinical history is going to change everything. If I were to show you a static image like this, and I would say, what's going on? Take away the subcutaneous emphysema, and this could be a pneumonia, this could be a cavitating pneumonia. If this is you need to know the history. If this is an infectious process, is this something that's been persistent for years? Is this, but obviously we're talking about trauma here, but the first point I just want to bring out is that you really need to take into a little bit of the clinical picture to be able to interpret these findings. So it's a linear type opacity consolidation. I want to bring out to your attention that you can see there are these foci of gas, right? Sometimes we, in a pneumonia or something, we would call them cavitation. We're not going to call them in these cases, but I just wanted to bring that to your attention. See, here's also pleural effusion. And obviously, you can see a lot of subcutaneous emphysema. So if you can try and get a picture of what's going on, often I think the first thing to do is have a look at the scouts. That would be my first tip. Scout radiographs are, a lot of the time, hands up, I sometimes do it as well. When you get your CT, you go straight into the CT, but take a step back, look at the scouts, and you can really pick up, first of all, things that won't get imaged. You have to realize the scout is only a radiograph, is only a set for really the text will decide on what they're going to image on the study. So if they decide to cut off an area that you're not imaging, you're going to miss very important findings. So therefore, just pay attention. You can obviously see it's a very distended stomach here. But what's really relevant is you can see the chest tubes in place, but you see a bullet, probably see some shrapnel here. You can clearly see the opacity that we were looking at. And that is going to be helpful for us. We're going to go back to our CT axial images. And we can pay attention now that this is probably what happened. He probably got shot. And you can see shrapnel here. And you can see the gunshot trajectory going through this rib here and destroying this rib. There's gunshot and probably bone fragments, and then it comes out here and it goes all the way out to the anterior skin through here. So we kind of get an idea of what's going on, and that's the first image. That's the first sort of thing I want to bring out to you, which is we have a consolidation and we have these foci of gas within the parenchyma. Obviously, there are other findings, pneumothorax here, and a lot of other things, but we're not going to go through them. Okay, that's the first case. So we'll pick up now in a second. So we're going to be discussing mainly these parenchymal type findings, how we're going to describe them, and we're going to start by first defining this. And I think that I like to think personally, before you spend any time, you're about to spend an hour with me, you should try to say to yourself, well, you're giving away your precious time. What am I going to walk away with this precious time for an hour? This is one of the slides, very straightforward, very simple, but one of the things I would like you to walk away with. There's a couple of things. So if I just summarize already, if you could take away one thing, these things I'm sure you already know, and just maybe review for some. No, scout radiographs are very, very important. That's number one. Put that away in your bank of information for I'd like to give back as much as I can, take away from this hour as much as I can. But the next things I will not talk about is parenchyma injury. So we're going to divide them into, let's start with contusions and lacerations. What's contusions? Blood and edema fill injured alveoli and the interstitial tissues. And essentially the underlying lung parenchyma is intact. So I alluded to this in terms of how, when you look at a CT or even when you look at a radiograph, it's very hard to know what's filling an alveolar space. Alveolar should be filled with air. And if it's filled with air, then it should be loosened. If it's not filled with air, it can be filled with pus, it can be filled with edema, or it can be filled with blood. I think that's the main one. So if it's edema, we're talking about it, pulmonary edema sometimes. When it's pus and other debris, it could be talking about pneumonia. In this case, we're filled with blood and edema. So it's really a blood-filled alveoli. That's what we're going to be calling contusions, as opposed to, you could call them, if you would describe them as consolidations or opacities within the lung parenchyma, which you would favor to be contusions given the kind of picture. The next thing I want to bring out is this. There's something called lacerations. That's different. That's a second stage. They often come together, but that's where the lung tissue is disrupted. And now you form these round or ovoid cavities. And within them, you're going to have various amounts of blood and gas accumulation. So a laceration is where the actual lung tissue has been disrupted. We're going to discuss why they're round or ovoid in a few minutes, seconds. Can't remember where the slide is, but we'll come across it very soon. And it's the lung parenchyma is destroyed, and then that lung parenchyma that's destroyed creates a cavity, and you have blood or gas, various amounts of blood or gas. Now, if you have a confluent region of intraparenchymal blood that you can no longer see the underlying pulmonary anatomy, that could be a hematoma. Now you can see how that could easily sort of cross over into contusions as well. And also when a laceration, a cavity is filled with blood, it could also essentially become a hematoma. So that is sort of take-home slide number 2. So a lot of this I spoke about, a lot of this we'll discuss. So contusions, as we just mentioned what they are, mainly the most common type of parenchymal image injury. They will be seen in most of the cases in 75% of blood trauma. They occur at the point of energy absorption. They're often peripheral. The lower lung can be affected more commonly because they don't have the overlying chest wall. We saw this in that first study. They don't respect anatomic boundaries. So if you're looking at a picture, and often these cases aren't straightforward because somebody gets injured, let's say in a motor vehicle accident, they're going to maybe become comatose and aspirate. So now we're going to have a question of, is this aspiration? Is this pneumonia? Is this contusion? I don't necessarily know. So if it's something that doesn't respect the anatomic boundaries, fissures, or doesn't follow in a bronchovascular distribution, I could lean towards saying, I think this is contusion as opposed to a pneumonia or aspiration is going to be more dependent. It's going to be respect those anatomic boundaries. Obviously, there's a big variation. They can be very small. They can be massive. They can take out the whole lung, and they can therefore result in clinically affecting the patient significantly with hypoxia. They vary also in their appearance. They can often be mild ground glass. If you see, let's say, rib fractures and you see peripheral mild ground glass opacities, that could also be contusion, and if you see severe consolidation. That is descriptors of contusions. Typically, in terms of when do we expect to see them and when do we expect them to clear? So typically they're clear within the first few days of injury, and you would expect them to clear within 2 weeks. The exception is, like we said before, if they're very significant, they're going to cause hypoxia. And in this case, let's say you have an increased risk of contusions when it has a greater than 20% of the total lung volume, you can develop ARDS. But assuming it's not that significant, if they should be clearing, and you would expect that 2-week process to be going in the right direction. So if they persist or they start to increase, then feel comfortable and feel confident to say, not sure why they're getting worse. I think there's something else going on. It could be that this is pneumonia that's superimposed on top. As opposed to lacerations. Lacerations tend to take a little longer to heal. And they're not seen that often in blood trauma, and they're more commonly in penetrating trauma because it makes sense. The lung parenchyma is being destroyed. So if you have a gunshot wound or a stab wound, it's going to lacerate as any other organ. Why are they round as opposed to linear lacerations seen in solid organs? Pretty straightforward, but just worth knowing and understanding that since the lung tissue has elastic recoil, you're going to get radial retraction of the lung parenchyma. So as it pulls it apart, so if you cut something, normally, let's say you have a laceration in the liver or the spleen, and then here, because of the elastic recoil, it's pulling out, and therefore you end up having a cavity. And this cavity, how would you describe it? Depends. If it's filled with blood, like we mentioned, it can become a blood-filled laceration. If it's air-filled, you can call it a pneumatocele. And if it has both, you could call it a hematoneumatoceal. You could say there's a blood flow, an air fluid level, or blood fluid level, blood air level, air fluid level, probably better. And essentially, you could describe it in that terminology. So often, if you recall back to that image before, we had consolidation, we would call contusion with some foci of some pneumatoceles, compatible with laceration. Generally speaking, where are they located? They can conform to the track of the penetrating object, which is what we saw. They can be peripheral ones from rib fractures. You can have large temporal ones and paravertebral ones, depending where the injury is taking place. Okay, case 2. Yeah, I guess in the way of my writing. Okay, let's try and read it to you. 22-year-old male, no significant past medical history. He's had a motor vehicle accident. He's driving. He lost control of his car. He went over the guardrail and down a 50-foot embankment. Unfortunately, not recommended, was not wearing a seatbelt. And he was ejected from his car, found pinned under the car, and they had to extract him from the car. They had decreased breath sounds on the right. The needle decompression was performed. The needle decompression on the right, and the rest of it I just took out from the charge just to make this more clinically relevant. Okay, this is the first radiograph. I believe this is taken before. Sometimes, like I mentioned before, if the patient's unstable, they're not going to have imaging, they're going to be intervened already. So let's pay attention to what we can see. It's granted, it may be a little hard to appreciate, but there's a couple of findings that are worth pointing out. And as we go to the CT soon, we will clearly see things. We'll try to come back to this image or review it. So just give you a second to have a quick peek to see if you see anything. I don't want to take away your radiological fun. Okay, maybe I should have given you a little bit more, but that's in the interest of time. So here is the needle decompression, right? That's what they stuck in. Do we see a significant pneumothorax? Probably there's one. Don't really see one much going on. There's a couple of findings we will focus on. If I can, it will become very apparent soon. But you can see here that this appreciate there's like a lucency here, and I'm going to reiterate this. I tend to be very repetitive, but points that I think are useful. If I were to show you this in a vacuum, this could be a cavitating pneumonia. If I were to tell you this is a somebody who's got a fever and a persistent coughing up a lot of spume, you would be concerned that there's some sort of lucency cavitation going on here. I granted it is subtle, but you can also appreciate here there's some more lucencies. But based on what we've discussed until now, we would lean to suggest that this would point towards, being in a situation we see, cavities or pneumatoceles or airspace lucencies, that we would be concerned for something like lacerations. Okay, there are some other findings here, and we'll point them out soon. So let's see if I can go back to that image. I believe it's this. So this is our scalp. It's very hard to appreciate the lucencies here. This is where it is. Okay, so we're going to go here and I'm going to see how very dramatic this case is. It really is. It's one of my most dramatic cases of laceration. And we're going to go all the way up. And appreciate. So we do have these pneumothoraces. Okay, so they're small, they're tiny, they're small. We have, where is this? It actually looks like it's probably going into the parenchyma. I'm not 100% sure, but it could be that needle decompression is going into the lung parenchyma. But what's really, what we're really out to get here is this. You can appreciate these significant, these ovoid, large cavities, pneumatoceles. These are lacerations with fluid levels. These are pneumatoceles. They're throughout the whole lung parenchyma. Very significant. There's a whole bunch of findings on this case. And you see how that this really is a laceration that's full of hematoma here. There's obviously contusion as well within the lung parenchyma. And you can also appreciate here how you also have pneumomediastinum tracking up around here, and that we're going to discuss at a later case. But these findings are relevant at this point. The other thing I just wanted to bring out, which is why it's often useful to look at the scalp, is that I find for myself specifically, like, I don't know why, clavicles, I have trouble. Clavicles are tough on the axle. If you pay attention to the clavicle, this is something that just really doesn't belong. Kind of, what is that? Zoom in if you could. That's not normal. So let's go back and let's with our. I mean, obviously you have to be very systematic and go through all your bones, but you can see how this is clearly very abnormal, and you can see how this very distracted, displaced clavicle fracture there. And here you can appreciate, you can probably see it better on the bone recons, but you can appreciate multiple fractures. Where is it? Here we go. So a whole bunch of fractures going down its posterior processes of its spinal vertebra. So a lot of, obviously, goes without saying that when it comes to trauma, there's going to be a lot of multi-system injuries, but we're focusing mainly on thoracic today, so that's why I'm going to really just jump back to what we're talking about. So this is really just to sort of drill it into your head, very dramatic but significant cases of pulmonary laceration. So we've seen contusions, we've seen lacerations. Let's get back to business. So some of these images I show you again, the statics, and those bone fractures. Okay, so this is his radiograph that followed later, and it's important to know another point is that there is quick evolution of laceration. You can have very, an air-filled laceration can start filling up with blood very soon. So, what normally may think, oh, that there's a developing pneumonia, it's not necessarily developing pneumonia. You can appreciate now this looks a little bit more easy to determine than we saw in the prior radiograph. But I guess another nugget of information is if you're doing serial radiographs on these people, it may be that you've done radiographs and you haven't done a CT yet, and you see interval development, what looks like consolidation, opacity, nodular opacities. That shouldn't surprise you. That could just be that this laceration is now filling with blood. Catch that cloud thing up there again. Okay. Sweet. Be true to myself and look at the scouts. See something's going on here. Chest tube inside you. Let's jump to the So let's focus on the bones for this case. You can see there's already some fractures going on here. But what I would like to bring your attention is these multiple rib fractures. Contiguous, multiple ribs. And what's important to note is that not only are they contiguous, you have to count them, and I hate counting rib fractures, and you have to also determine that there are fractures in multiple segments of the same rib. So there's a fracture here anteriorly and posteriorly, and there's multiple of these fractures so this is that same rib, and you have a fracture anteriorly and posteriorly. That is an important thing, and we'll discuss why that's important in a second. I'll show you on just a different. So let's make sure we're in the right place. And we can appreciate how we have multiple fractures coming down here, multi-segmental fractures here, fractures of the same ribs, anterior and posterior, and contiguous throughout the whole lung. A lot of subcutaneous emphysema, and chest tubes in. Interest of time, we're going to move on. Okay, so this is a nice 3D recon, and you can appreciate very clearly here how the multiple contiguous segmental things, sometimes it can help just looking at the 3D recons, and it can be very helpful just to get an idea of what's going on. But you can appreciate how multiple of these actually, but there's multi-segmental thing. Here's the chest tube coming in, and that gives you an idea of what we're doing. So let's talk about flail chest. So let's discuss some terminology. Rib fracture. It's a rib fracture. It's a displaced or a non-displaced cortical break. Okay. Now you can have buccal rib fractures, where just the inner cortex of a rib is damaged. But you don't have it. It's like what we usually associate buccal fractures with children. You can have that with a rib. But a displaced or non-displaced cortical break. Now comes the next level where it's a segmental rib fracture, which is where you have two fractures in the same rib. So a flail chest. Now, the terminology that we use, or being able to define it, I don't think is that relevant. But I think the point is, this is a clinical situation, but it's something you should raise the suspicion. If you see 3 or greater than 3 segmental rib fractures, so essentially that pit of the rib is could be removed, or there's 5 adjacent rib fractures, contiguous ones, you can raise the clinical suspicion of question to saying this is compatible with flail chest. And that would be something that they would have to, surgeons, thoracic, the trauma team will have to determine if that patient has clinically significant flail chest, or if they have to deal with those rib fractures in a way that prevents them from having clinical consequences. So it can occur, decent amount, 10%, 5 to 30% of patients with chest wall injury. The flail segment shows paradoxical motion with the respiration. What's the most common rib fractures? 4 to 9, the lower down, they get fractured harder, they get fractured more. This is another nugget of information that's important to know. If you do see a first rib fracture, since the first rib is protected by the clavicle and the scapula, if there is a first rib fracture, that should be like bing, bing, alarm bells. And the alarm bells means that this must have been a big whopping accident or been a lot of trauma that it managed to break that first rib. And if it broke that first rib, then you should, which, you know, you should always have your suspicions, but raise your suspicions for looking for other types of trauma, bronchial tears, aortic transections. Be aware that this is a much more high impact injury. Sternal flail can occur when the sternum becomes dissociated from the hemithoracis because of bilateral multiple anterior cartilage or rib fractures. Let me just go back quickly and make sure that I wanted to make sure this is that case. Yeah, so let me just show you this. So if you look here, this is probably the best. So you go to soft tissue windows, you're looking at soft tissue, and pay attention to the costochondral cartilages here. So these are the costochondral cartilages. So don't just look for rib fractures, also look for costochondral cartilages. And you can appreciate here that this cartilage is severed. Let's zoom in a little bit. I think granted it's not the most prettiest image of the three, but so if you look here, you end up having a disruption of the cartilage here as well. And can you appreciate that? There's a little gap here. So you can see it here and you can see it here. So I often like to use the coronals for those things. And what I'll do is in soft tissue windows, I would scan through as you come very anteriorly to try just to count them out and make sure I see them. And often you'll catch something there. You're like, oh, what's that? And then just go back and look on your axials. And you can see that there's some disruption here of the costochondral cartilage. And you see that as you go further up. Okay. So this is what a flail segment would look like. And this is what it, we're referring to paradoxical motion. And inspiration, this caves in as opposed to expanding. And in expiration, it expands out. Okay, let's look at our fourth case. See, gave it away. So I'm going to just, for the sake of going out of my normal routine here, but I want to just show you something. So if you look at this case, it's an interesting case. A little older, but it's given to me by my thoracic surgeon. I think it's a really great case here. So let's just focus firstly on, if you're looking at the bones. Now, I would want to point out one thing. As you come, now, you appreciate in a normal CT, what you hope is the patient holds their breath. When the patient is trauma, in a significant trauma, we're not talking about people holding their breath here. We're talking about quick, speedy scans, and there can be a lot of respiratory motion artifacts. So respiratory motion artifact, often, as you can see here, you see this blur here. This is respiratory motion artifact. Okay. Often, I'm sure you appreciate it when you're trying to look at rib fractures on someone who's breathing. It's very hard because you're not sure of the double line of the cortex, if it's a respiratory motion or if it's a fracture. But as you come down here with this respiratory motion, you could be fooled and think, oh, it's just respiratory motion. But I would like to point out to you that if you look on the sagittals in this case, so for example, this is respiratory motion. You see how the skin line is in and the skin line is out here. That's because the patient's moving. That discontinuity is purely respiratory motion artifact. Okay, and that, this also, you can see here that this is also respiratory motion artifact. But if you pay attention, this is clearly more than just respiratory motion artifact. So I would point out to you that I don't think any one of us would have proposed that this is all respiratory motion artifact, but I just want to point out you can have respiratory motion artifact, but you can also have a fracture in that region as well. And so you have here displaced, multiple segments of the sternum. And you know, I guess my other nugget is I want to just take out is what I mentioned before. If you look at the scalp, it really is quite evident there's a fracture here. You don't, since it's like a static image. So look at those scalps. Pay attention to the sternum on the scalps. Pay attention to the sternum. Or, you know, like I said, other parts of the, you know, look for humeral fractures that you might not catch on your study. One other thing from this note. So this is a sternal flail segment or sternal, you know, fracture. But I would want to just point out one other thing. If you come down here, and this is important. So if you pay attention, which one part of our systematic work through will be, make sure that you pay attention to so something you can use lung windows or soft tissue windows, and you can see here there's a lot of pneumomediastinum. And as you come down, and then not this, I don't know if I have with me. Bear with me. This is better. It's just loading up. You can appreciate here. Can you see that? You can see how there's pneumomediastinum, and you can see in the right bronchus, there's a discontinuity here. This is a bronchial tear. So pneumomediastinum, start looking. Do you see a bronchial tear or not? Is there some sort of, you know, damage? There are. So what are the damages? We'll talk about them in a few minutes. The esophagus could also be injured. Usually more fluid with esophagus and less pneumomediastinum, but you can have both. And often you can have pneumomediastinum from a macular effect that comes in through from the pneumothoraces and things like that. But you want to exclude a bronchial tear, as you have here in this case here. So this is that image just to show you how clearly you can see sternal fractures. And then this is the video of this patient. I'll try to, if that's coming across, you can see how as he breathes, his sternum is paradoxically moving here, flail sternum, and needed to be. I believe the next image could be quite graphic. So if you're eating your lunch, dinner, breakfast, whatever time you're on, you may want to look away. So here's maybe our surgical resident can help me. But essentially what is going on here, we have our fractures of our rib fractures, which I believe not well delineated. This is the IMA, and you can see some, essentially what I went over this with my surgeon. I just can't remember all the details right now, but essentially what you have here is this is what we're looking at, the sternum region here. And this is what they had to do. They put an ORIF for the sternum for that flail segment, and from the multiple rib fractures, we didn't really pay attention to them on our CT. And this is what a patient looks like. In a radiograph, you can see how you have the sternal fixation devices and the ORIF for multiple ribs. And this was a repair for the bronchus, which had the bronchial tear. And that is that story. So let's talk about an airway injury. Okay, airways injuries are serious and therefore often precludes imaging. Those who do make it to injury are likely to have a bronchial injury than tracheal injury. Tracheal injuries are very serious. You won't see these people. Bronchial injury will make it, hopefully. Tracheal injuries from blunt, most commonly around the carina, and commonly involves the posterior membranous trachea. So all these pieces of information are just pieces of information that should hone your skills. So if I'm looking for a airway injury, pay specific attention to the posterior tracheal membrane. Make sure you focus at the carina. That was, our case was a little bit more already into the right main stem bronchus. You can have if it's a blunt injury, you can have disruption or shear injury. The right is often seen more than the left. And this is a shorter path through the mediastinum. It's less protective. Pneumomediastinum is most common. I mentioned how it can be caused by macular effect from parenchyma injury dissecting centrally. But however, if you need to be aware if there's pneumomediastinum, make sure you pay a specific, focus carefully on, to exclude any airway injuries. Esophageal injuries, I spoke this out already, usually less air, and they will have periesophageal and accompanying fluid. Okay, take a breather for 1 second. I'm drinking way here. So let's just review a little bit, and we'll move on to the next few more cases that we have left. We've discussed the importance of scouts. We've discussed the importance of, we've looked at parenchymal injuries. The main things I want to take away or review are things like contusions and lacerations, the sort of evolving change that can occur with lacerations, so that it can be from a pneumatoceal to a hematoneumatoceal or to a hematoma, and that can change in imaging. We've spoken about the importance of making sure that you look systematically through every study. We spoke on this previous case. Now, when you do see pneumomediastinum, pay attention specifically to looking for airway injuries, and we'll review hopefully if I can remember anything else that we talked about. But up until now, let's discuss here. Okay, take a little bit of a change of pace for a second. So so this one is another study. Let's look at the radiograph. It will help. There's a bullet here. You have different institutions have different ways of showing. Sometimes they'll have an open. They'll put a paper clip for you where the point of entry was, and that's something that you should communicate with your trauma team to make sure that they can guide you if they're trying to tell you where they think the entry point was and where the exit point was, or where they, if you just see an entry point. We see a bullet here. We see a lot of opacity here. We see something funky going on with the bone. We're going to appreciate that a little bit more in a second. So as we come down, you can see how this is the bullet, and it's in the bone windows, and it's in the left clavicle. We'll try to work out what happened here. We can see how this is probably the trajectory. The scapula was shot through. The patient was shot at the back here through this, shot, I guess in an angle going like that. So the gun up against an angle. So it went through this, the bullet went through the scapula and lodged in the clavicle. Let's have a look at the lung parenchyma. So based on our knowledge that we have and we've discussed, we can appreciate this consolidation here. So hopefully we would call this, it's so sad that we can't, I wish I could hear everybody, but I imagine everyone saying contusions, which is a contusion. And then these little pneumatoceals or cavitary things we would call lacerations. So this is a large contusion in the left upper lobe, left apex with, lacerations, and you have a bullet trajectory going through the scapula, through the ribs, and the bullet landing in the left clavicle. Now, one thing we haven't really touched upon, we've mentioned it sort of briefly, but you want to pay attention to vessels as well. Vessels obviously are something that can get injured, and in this case is at the purpose of this case. So let's have a look what happened here. So you can appreciate, if you pay attention to we'll go this way. Here comes, this is the subclavian going into the axilla and axillary artery, and you can appreciate here this is not normal. There's a large irregular, let's see, I hope everybody can see that nice and clear. So as it comes out here, you can see this. I don't know where my tools are anymore okay, I'm not going to measure it, but you can appreciate it here, and as it comes further out, you kind of lose the vessel. There it picks up, it reconstitutes here. So there's an area where the vessel really loses out here, and they have this thing. So what is this? Is this pseudoaneurysm? Is this, and you can see how this is, some blood products here, and this is the, so we know the bullet went through it. We don't have delayed images to tell you if this is an active, extravasation. It's a bleed. It could be a traumatic pseudoaneurysm that's enclosed, and that won't expand on delays. If it's a active extravasation, where if you get delayed images, you would see this dissipate out and expand out. Now, at this point, it's pretty evident that this patient needed clinically speaking, he had weak pulses, and they took him to surgery to explore what was going on here. Where did I? Okay, so here is the axillary artery, and if you can appreciate here, I'm going to zoom in a little bit. This part of the artery is missing. Okay, this part of the artery is missing. Okay, so the bullet took a slice out of his axillary artery, and this was just actively bleeding out. Go back into that image. This is the vessel, and this is the area that is being cut out and by the bullet. And then they put in a porcine graft here. This is the stitch here. This is the thing. They put in a graft of the axillary artery. Now you see this vessel now, because this is the vein that was, since he was bleeding out so much, his venous return was so minimal, so we didn't see the axillary vein on the original image, but now we see that. So that is an important point to take home. Make sure you pay attention to vessels with any type of, especially penetrating injury, stab wounds, gunshot wounds, and focus. Obviously, we're not going to really talk today regarding aortic injuries, but that's also going to be it's a major topic that needs to be discussed as well. Okay, how are we doing for time? I'm going to go to the end. I think a lot of information, but I'll just do a few more cases and we'll see how we go. Okay, so this guy, multiple gunshot wounds to the back. This is an interesting case. And let's look at their original. So he got shot, multiple gunshot, he had diminished breath sounds on the left. He was intubated for airway protection, and left chest tube was placed. And we'll go back to let's go back to the first study that we have from there. So there's a lot going on in this case. I'm not sure if we're going to focus on anything, but I just want to point out one thing. So I had mentioned that you're looking specifically around the mediastinum, and if you can appreciate this mediastinum, it is very not normal. There's a lot of mediastinal edema, infiltration here. The soft tissues are not normal, and you want to pay specific attention to where every little focus of gas, like what is that there, what is that there. As you come down and you focus around the esophagus, this does not look normal in terms of it's very ratty, it's very edematous, and there's a lot of things. So there was concern from the esophageal injury here, the multiple gunshot wounds. He has a lot of subcutaneous emphysema here. We know he's been shot here. There's questions of what if this was a bleed. It wasn't clear, and they took him to surgery. And essentially, let's go back to what they found. There were some parenchyma injuries. They did an EGD, and they saw mucosal changes at the 25 centimeters from the sizes, so down, and it was concerning for injury. And essentially that, they didn't see any major, they saw some mediastinal bleeding from an inordinate vein. It was a venous vein. It was a venous vein, but that was essentially the sort of first part of his course. As he went post-operatively, he followed out for a while, and everything was doing okay until we ended up reading a radiograph. I'm gonna jump here in a second. Then I'm reading this radiograph out of a few days later, and as you can appreciate, this is the enteric tube going down, but it has a very interesting course. There's this new big blob here. Okay, blob is not a radiological term, but a paratracheal mass paratracheal, opacity that didn't exist before, and that was something concerning. So they took him back to sort of reevaluate what was going on at this point here. So let's go and have a look at that study. Okay, so this is what it is. So you can appreciate, I'm going to come back down here. So this is his study. As you come down now, this is it's very challenging, not the greatest of images. He has a lot of chest tubes and things in it, but you can appreciate this. It's large, low density, it's fluid density. Fluid density, big collection in his mediastinum. It wasn't there before. The question is, what was it? It didn't look like blood. It it's not hyperdensity. It would be too, you would expect some sort of hyperdense areas at the fluid level if you would expect in some sort of region that was in blood, but it wasn't clear what this was. They ended up taking tube out. It was sort of milky, and it turned out to be that he had a thoracic duct injury. Thoracic duct runs down there, and he was ending, I think that was resulting from a thoracic duct injury. Okay, I believe this may be our last case. Okay, so scout, portable radiograph. Busy going on down here. It's very hard to know what's what. The retroquatic region is very, and if you look here on these CTs, as you come up, you can appreciate how, even if you don't know what's going on, something just doesn't look right? The stomach looks very high. There's a lot of atelectatic lung, very, the parenchymal opacification is very high, so it doesn't, you favor this to be atelectatic as opposed to pneumonia. And it's probably going to be easier when we just jump to the chase and we look at the coronals. But if you don't window well, you would say, okay, looks okay. But if you window, you can appreciate. I'll just put up for the sake of it. You can appreciate the stomach is where it should not be. Okay, so the stomach's all the way up there. And if you look here, you can appreciate here, this is the, you can see a diaphragmatic flap here, but it seems to not follow through. So we have a diaphragmatic rupture with the stomach projecting into thoracic cavity. So it's a high energy blunt thoracoabdominal trauma. Usually get a sudden rise in abdominal pressure, can rupture the diaphragm. Lateral impact can distort the chest wall and shear the diaphragm. So usually the diaphragm will separate the positive intra-abdominal pressure with the negative one. So from the thorax, so the pressure gradient is going to favor intrathoracic visceral herniation, and that was the case in our case. And generally speaking, what you're looking for is the signs that you would look for would be dependent visceral signs, which is you herniate about or viscera no longer supported posterior by the diaphragm. So in our case, the stomach contacted the posterior ribs. I guess we can look back at that in a second. Or no, that would be on the left, or the right would be the upper third of the liver would contact the posterior ribs. Stomach or the bowel would be posterior to the spleen. You can see direct visualization of diaphragmatic discontinuity. You don't necessarily have to see. We did see it in our case. We also have a collar sign where you have the visceral herniation with a focal constriction, so it just kind of pushes out. You can have diaphragmatic thickening where it's just pulling back from the retraction. Very helpful to look at your formats. I think generally speaking, I'm a big fan of always using your coronal and sagittal for everything. You have to realize that yesteryear, they didn't have those reformats so easily available, and therefore a lot of skills were developed in using axials, and just great, and they're useful to have. But make sure you use your coronals and sagittals so that we can make things much clearer for you. So that is essentially my talk. I think that 1 second. Let's just briefly discuss review. I'm going to go back quickly in this way, just so we can just go over the cases very briefly in this, we discussed the main thing I wanted to talk, we spoke about contusions and lacerations. We discussed how contusions, the lung parenchyma is intact, while lacerations, you're going to have disruption of the lung tissues, and that's why you end up getting we spoke about how since there's radial retraction, elastic recoil of the lung parenchyma, you'll end up having a cavity as opposed to a linear laceration in other parts. Hematomas we mentioned. We discussed how they usually, don't follow the anatomic boundaries. They go along the trajectory. They can vary in appearances. We discussed how the importance to realize that they do clear within 2 weeks. You'd expect them to start improving. If they don't improve, start to consider maybe that there is additional issues going on, maybe the superimposed pneumonia. We spoke about the variations of hematomas, pneumatoceles. We saw a few of those cases. We spoke about flail chest, the importance of paying attention specifically to segmental rib fractures. Are there more than one fracture in the same rib? Pay attention to that and make sure you note that if there's greater than 3 segmental rib fractures or they're contiguous rib fractures, you want to raise the suspicion of flail chest. We mentioned how the first rib, if you see that, that should have a heightened awareness for other types of serious injuries, because since the first rib is protected by the clavicle and the scapula, we would be concerned that we're talking about a high energy thing. Airway injuries we spoke about, bronchial injuries, look posterior membranous trachea specifically. If you see pneumonia mediastinum, have a heightened sense of awareness for it, right greater than left, mostly around the common carina, around the carina for the tracheal injury, but expect that tracheal injuries are very, serious, and therefore you may not see them, so pay attention for bronchial injuries. Esophageals, we saw that case with a lot of mediastinal fluid from an esophageal injury, and usually less air. We saw this case of the axial injury, axial artery, so pay attention to vessels. We spoke a little bit about other potential causes for mediastinal phlegm, the thoracic duct injury, and then we ended up just now with the diaphragmatic rupture with different signs of that. And that's me. Okay, I think there might be some questions and answers there.
Yeah, thank you so much. Yeah, go ahead and you can get to the questions and answers in the chat. That'd be great.
Okay, so Dr. Mahesh, how to calculate ribs for fracture identification and axial scans? How do I calculate the lines? I'll tell you, there are many different ways of doing it, but what I personally use the sagittals to align myself with the first rib, and I count down on the I use the sagittals. You can either go, see if we can bring one up. Bear with me. Hold on, sorry, I'm losing myself. So you could either do it something like this. Let me just move this out of the way. Bear with me. So let's say we went to something like it's a good rib care. It's just the rib fracture cases that we had. I think this is a bunch of rib fractures. Yeah, so what I often do is I will put the sagittals up against I know you were asking me specifically, you asked me about the axials, but what I tend to do is I just tend to have the axials and the sagittals up together at the same time, and I line up my first rib, and this is my first rib, and I know that I'm here, and I can find it up, I line it up here, and I just count down as I go, and go through using my sagittals and coronas. I like sagittals to start with, and then I pick up and then I just count through. But the different methods, and I guess you have to play with what you find is efficient and useful for you. The second question was recap or laceration. I'm not sure if that was prior to my recap or after my recap, but essentially the laceration really just the purpose of the recap was really, well, just go back to here. Definition wise, go ahead.
Oh no, I think I appreciate the recap, and once you are done explaining that, I'll ask another question. Okay.
Laceration is disruption of the lung tissue, while contusion is not disruption of the underlying lung parenchyma is intact. It's just the alveolar space is full with stuff, while laceration you end up having the lung parenchyma is being affected, and since it's no longer intact, the elastic recall of the lung is going to pull it apart and create that cavity. That cavity then obviously is going to either stay with air or fill with blood or variation.
Great. And one thing I was wondering was, you've given us a really excellent overview of the different types of structures that can be damaged. What, in your experience, are the most easily missed injuries that can really stump, especially radiologists in training on CT chest?
It's a good question. So I was always told that, like, when you say, "Oh, this is the first time I've ever seen that," they used to say, "Well, that's what you think." So it's hard for me to know what I've missed. But generally speaking, I think for me, rib fractures are very hard. Rib fractures can be easily missed, especially, so I think you need to, be systematic, paying attention to, when it's obvious, like a lot of these cases, it's not diagnostic dilemmas. I think that generally speaking, being systematic and having I think in training, that's the most important thing I can, give a credit, is just develop that routine of, not just trauma cases, but everything. Having use your, I have word problems right now, but use your template that you have, and you go through things in the same way for every study. And that's really important because, in the real world, I'm sure as residents and wherever, I'm sure there's different people on different levels of their training here, that you will be interrupted multiple times. And if you don't know where you just got up to, you won't know where to pick up again from. So if I know that I'm stopping here at bones or lung parenchyma, I know that means my next part of the study is, so if someone interrupts me with the phone, or someone walks in, or something happens, I can pick up again. Otherwise, you're going to find yourself going back to the beginning of the study, something, did I do that? I don't remember. Did I look for bones? And so I think a systematic approach, especially for trauma cases where there's so much going on, is really crucial.
Great. Well, it looks like there's no more questions at this point, so we can end a couple minutes early. Thank you again, Dr. Aylis, for joining us and giving us this wonderful overview.
Okay, pleasure. Thank you so much for having me. I wish you all well. Have a good day, good morning, good afternoon, good evening.
And thanks for everybody for joining us.